Just recently, there was a meeting of the minds, an assembly of innovators, stakeholders, and thought leaders in the management of benign prostate hyperplasia at the annual meeting of the Society of Benign Prostate Disease, which was hosted in Dallas this February. It was an honor to be included as an invited guest speaker at the meeting, and I wanted to be able to share with our listeners a behind-the-scenes look as we review some of the key takeaways of the meeting, and we'll get you up to speed with some of the new technologies available in the evaluation and management of BPH, as well as a sneak peek at some of the new advances coming down the pipeline. Joining me today is one of the Society of Benign Prostate Disease Board of Directors, Dr. Kevin Zorn. You'll definitely want to stay tuned. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On the podcast, we'll be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. The Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm excited to have joining us on the Prostate Health Podcast today, board-certified urologist Dr. Kevin Zorn from the BPH Canada Clinic in Montreal. Dr. Zorn is a former Associate Professor of Urology at the University of Montreal and the University of Chicago, subspecializing in robotic surgery and BPH surgical care. Dr. Zorn's career has consistently been hallmarked by research and innovation. Among his many firsts, he was a first in Canada and Quebec to use many new BPH technologies, including Greenlight XPS, Rezum, ITind, Optilume, and aquablation. Dr. Zorn is the senior author of the BPH guidelines for the Canadian Urological Association and has authored 345 peer-reviewed publications and 12 book chapters on BPH and minimally invasive surgical care. He has traveled to lecture, teach, and proctor surgery around the world and is intimately involved in the development of several new pioneering BPH technologies. Dr. Zorn, welcome to the Prostate Health Podcast.
Thank you. Glad to be here.
Dr. Zorn, it is predicted that urologists will be seeing a tidal wave of men seeking care as they suffer from late-stage BPH, overwhelming healthcare systems. Our listeners here on the podcast not only include physicians, innovators, leaders in the medical technology industry, but also savvy men and their loved ones looking to improve their prostate health. All of our listeners I know would want to get up to speed with what we've learned at this year's Society of Benign Prostate Disease meeting and how we need to equip urologists with as many tools in their tool belt of how we're able to evaluate and treat men with an enlarged prostate. Dr. Zorn, you had several insightful presentations at this year's meeting. I really appreciated your discussions on how we are able to utilize new technology in evaluating men with an enlarged prostate. Could you enlighten our listeners with a few of the highlights from your presentations on the workup of BPH in the modern clinic setting?
Absolutely. It's a big fish to kill here, but I think the first thing is, the workmanship in terms of the number of urologists out there who are going to be able to offer urology care may stay stable for the next 10 years. And we know that men over the age of 60 and the whole population over 60 will double or triple in the next 10 years. So certainly there's a numbers game of ability to make the diagnosis and do treatment. We know also a lot of men, as they go through prostate puberty, their prostate grows starting at 50, 60, and there's various different growth rates. And to have access to a doctor or a urologist to work them up is going to become more difficult, and which unfortunately leads men to often present later in the stage where they are in retention. They have a catheter, they have infection, they have stones, and we miss the boat on that earlier detection and getting in there to treat them and save their bladders earlier. So what are the tools that we have? So other than cloning urologists and increasing the workmanship force of other providers, I think the use of technology is going to expand. And we've seen that with Amano, we've seen that with ProudP, a few other app-based devices where they can use their cell phone. Patients can at home download this app and record simply leaving their phone by their toilet. So when they urinate, there's the sound of the urine hitting the water and the toilet bowl giving a certain resonating pattern, which the app can then predict what the flow rate is, can determine how much came out, and the time of voiding. And so it gives us a pattern of either a bell-shaped curve or a flattened curve showing early signs of obstruction. So I think that's part one. Other potential technologies that I think we're going to see is greater use of what's called point-of-care ultrasounds. So in Canada, to get an ultrasound, we have to fill the script, give it to the patient. The patient has to make an appointment in radiology, go for their ultrasound. The technician doesn't give them an answer right away, that she, if it's a female, and then the patient will go home and have to make another appointment within a month that we go over the results, because it takes that time for the report to be generated, completed, signed off electronically, and then sent over on the EMR to our record. So there's a time gap. Can we shorten that we have using our cell phones as a physician, connecting with a small handheld ultrasound? That we can determine the prostate dimensions, size, volume, bladder wall thickness, if there's stones. So that kind of technology I've adapted into my practice with Clarius. There's Butterfly IQ and a few other devices that can allow the urologist to become, in some sense, the radiologist, which we're very familiar with. I think yourself, most urologists are very comfortable with ultrasound. It's safe, it's cheap, it's effective. So the combination of those two, I think, at least for the next few years, can save a considerable amount of time for ourselves and the community of physicians, as well as to the patients and their busy lives as well.
It's certainly exciting to see some of this new technology being implemented and available for urologists. I mean, even like from a workflow standpoint, to be able to do some of the, have some of these tests done in the comfort of the patient's own home, not only I think some should be more accurate, kind of their normal flow patterns, but also from checking the patients in the urology clinic and trying to have them do the uroflow, just to have that test already done, or as a follow-up to be having that information coming in from home, I think is very exciting.
Yeah, and to add to it as well, I think our job and why we love urology is we like bringing in new technology. We like having a better patient experience and less invasive, because one day it's going to be us there. And I think we're just, in terms of our personalities and the evolution of the specialty, to bring in technologies. The third one that we talked about was the Eurocuff, which again, in the past, if we want to know someone's obstructed, but is there some degree of bladder failure, what's that contractility, right? But simply to the listeners, flow is pressure over resistance. Certainly our job as surgeons is to relieve the resistance, but what about that bladder? Is it contracting well? Is it hyperactive? Well, the tool that we can use in the past was urodynamics, which involves these tubes going inside, and it's invasive, it's unnatural to bring something on that sits like a little vacuum on the male phallus, that as they're urinating, there is a cuff of air that squeezes the urine flow. The patient doesn't even feel anything except for the device against the tip of their penis. It can generate and determine what's called PDET, the true serum pressure, to know, is it a weakened bladder? Is there some signs of obstruction? And what we get printed up is a very simple, 4-quadrant, where's this patient? And that can help us perhaps identify those who are compensating. Their bladder is working twice as hard to get urine out, and it's going to, eventually fail. So that would be another tool where I think, it's been around for a few years now and probably underutilized, but I think that kind of technology too may help us answer, how do we identify patients who are in the quicksand and they're deteriorating, but may not notice it on subjectivity or simple questionnaires like the IPSS, or on the Euroflow, which, as you said, it's a bit awkward, sir, come over here, urinate in a bowl on demand. Doesn't always necessarily compute with what actually happens on a day-to-day for that gentleman.
Well, it's certainly been exciting to have new and innovative technologies at our disposal to help men with an enlarged prostate. Could you highlight some of the new technology that is available now, really over the last year, in the interventional management of BPH?
So again, another explosive fireworks arena. So compared to appendicitis, well, there's lap open or hernias. There's just a few ways of doing it. Well, with BPH now, we got the arena of meds. We can relax or shrink the prostate, Flomax or Zatrol or Proscar Avodart. Then we got on the other side, surgery, TURP, which, 1960s technology. We've gone to lasers and denucleation or Greenlight. We've evolved then into some of the other mists. That's a third category that sits in the middle, Urolift, Rezum, and now enter ITind with some of their newest data. Optilume BPH, which is a balloon that simply expands inside the prostatic fossa, creates a crack at the 12 o'clock position, and the balloon itself is coated with a certain chemical that prevents it from sticking together again. So it kind of opens up and creates a long-term opening of a line. So rather than creating a circle or a cylinder, it creates a higher urethral height. So if you're kind of trying to get something out of your suitcase, and you got a small little zipper opening, well, if you open that zipper another couple inches down, getting your hand inside the suitcase is a lot easier. There's your resistance reduction. So that's the Optilume BPH. So that's what we got now, certainly making our jobs difficult to more complex of a longer discussion with each patient. So going over their wishes, their desires, their wish for catheter post-op, sexual and ejaculatory recovery or preservation, etc. So that's what we got now. And what was discussed at the SOPBD, some of the upcoming stents 2.0, such as ZenFlow or Rivermark and a few other intraurethral stents, kind of like if you have a heart disease and rather than doing a sternotomy and open heart surgery, well, we can go in through your arteries and put in some stents and immediately open up the flow. So those are ones that are forthcoming. And in the meantime, we have ITind, which is a temporary one, which sits in place for the urethra for a week. And then we remove that, creating a very similar anterior opening like we would see for Optilume.
Well, certainly exciting times, not only for urologists, but for patients to have options. And when I look at some of these options for BPH, it's really not a one size fits all. And you probably agree with that, that it really depends on the patient's anatomy and their personal preferences as far as maybe which group of treatment options or maybe which particular one might kind of be best suited for them. But that is the key. We have options and minimally invasive options that can really minimize some of the side effects of the more traditional therapies.
And to add to that as well, I mean, to the listeners out there, I mean, certainly you have to know your numbers, like what's your IPSS score? What's your prostate size? Do you have a middle lobe? And then we fall down our AUA algorithm. It's the American Urological Association grid, let's say, is very, if then conditional. Are you medically fit or medically unfit? And based on size, we have different offerings. And one of the other ones that's come about and really has been, in my practice, revolutionary is the aquablation, which is robotic. So it now takes out the surgeon factor. You could be on your first day of work as a urologist or nearing your end of retirement. Someone who got an aquablation across the globe gets a standardized procedure. Kind of like if you go to McDonald's, you want a cheeseburger, you're getting a cheeseburger. You know what you're getting. A TURP, well, if I give that same patient to 10 different urologists, the amount of pathology removed, the hemostasis, the hospital stay, as we know, will be very heterogeneous, very different. Lasers as well. So at least with certain types of technologies as the Optilume, so I think that we're going to get standardized results between physicians. The aquablation certainly does that in the area of resection. So you can get this huge hole-up-like enucleation removal of the transition zone. You cure BPH. And at the same time, you preserve tissue around the apex, which most men who come to see me, their biggest fear is, I don't want to be incontinent. That incontinence rate immediately is really low versus hole-up, which unfortunately sometimes gets termed as transient incontinence. It can last several months or sometimes permanent. So that's something that's negated or minimized tremendously. And then you have the same time 85+% chance we'll preserve ejaculation, which is unheard of for TURP, laser TURP, hole-up, or any of the resective techniques. So that's another type of technology. It's been around for about 5 years plus, and Water 1, Water 2 data is very, I think, profound and very significant.
And you touched on this a little bit already, but in terms of side effects of medical and surgical therapy for BPH often include changes to ejaculation, which is a concern to our patients. This was certainly a common theme among many of the talks this year at the SOPBD meeting. Now, when comparing our available treatment options, how do they compare when looking at the risk of developing retrograde ejaculation after the intervention?
So with regards to being on medical therapy, I think most men have had some impact both on their sexuality, their libido, sex drive, and at the same time on their ejaculation. Meds tend to relax the prostate, so men's orgasm, the contractility, that manly squeeze is lost. And at the same time, I think that's more of an ejaculation. Their prostate isn't squeezing, so therefore there's nothing outputted. Versus after surgery, we get men off meds. They'll contract. Now the sperm's going the other way because of the large opening. So just to make sure that there's a difference between anejaculation, failure to ejaculate, or retrograde. So you are ejaculating, but it's going through the path of least resistance. You can either go through a urethra the size of a straw, or you can go through some of the aquablations 5 by 4 centimeter opening. So physics dictates that fluids or gas will go in a path of least resistance, which is toward the bladder.
And what are some of the tips and tricks that urologists can consider in terms of potential modifications to some of the more traditional procedures we offer?
So that leads into one of the great talks that was 2 lectures at this year's SOPBD, Dr. Gonzalez and a few others. They presented on modification. So number one, most physicians have one or two technologies they're familiar with. So either one, they can counsel the patients on all the options and refer them to someone who does those more convincing or well-studied ejaculatory preserving techniques, or they can do this sort of hood technique where rather than starting, that's the true mountain, verumontanum, we'll go a centimeter in front of that. So to leave some tissue at the apex and then start their treatment. That's been something that was presented so that if you can preserve the anatomy around the verumontanum. So initially, I would say about 10 years ago, we all thought it was the bladder neck, right? This is what was taught to us. And then we realized it's not. And aquablation helped understand that. Kind of like robotic surgery, Da Vinci helped us understand some of the prostatic anatomy, which we thought we knew of in open surgery. So some of our technologies helped us better appreciate physiology and the principles, in this case, of ejaculation. So the idea is that if you could, modify your technique so to be less aggressive at the apex, spare about 1.5 centimeters around the verumontanum or proximal to that, that therefore preserves the verumontanum. We don't burn it. And that hole that goes beneath, that's a bit of a mystery. We all know what the verumontanum is. We see the hole, but what does that duct system look like? Has that ever been well studied? The answer is not really. But certainly if you can, like an orifice, a ureteric orifice, as long as you don't touch it, burn behind it, around it, we know the course roughly, less likely it's going to get obstructed or blocked. So I think that's some of the understanding of, number one, yourself as a urologist, adapt your technique if you're comfortable with it to those patients really looking for it. Counsel them perhaps on other techniques. And like we've seen in the last 10 years, an amount of technologies let us, and certainly yourself and myself, who really enjoy helping patients with BPH, bring into our portfolio different treatments. So unfortunately, I think you had a nice presentation. I do CrossFit, certain people like, this is the only way and we can't vary from that. It's important to be a multi-sport person, or in this case, multi-technology, to be open and test out or choose the ones and have several different offerings versus having a TERP loop, and that's the way it is across the board, which some of us don't have a choice. We work in an environment where our hospital doesn't allow us or hasn't thought out necessarily the cost economics. And for that reason, some patients may not get access. One, the physician hasn't learned the technology. The hospital's not offering it. I guess the key thing is take your time, review through it. And that's why we built bphcanada.com, our website that really covers the lay of the land, and to which I'm fortunate I've learned all these techniques and I offer them all. Unfortunately, not all urologists do that. So I think that's the key thing, is try to be flexible, variable, open-minded, and learn some of these techniques. And it's coming, it's here. And I think in the next 10, 15 years, our residents will be passed that down, and that will be a way of care for all patients. And this is all a short period of evolution in the last 5, maybe 10 years, right? I mean, it's been TERP all the way since 1960. 2000, lasers came out. Stents had a short stay, but they were made of metal. And we realized that's not a good idea. Nitinol is better. And the shape and the amount of volume, and the urethra is not a tube. So this is what we've learned along the way. But I think we're very young in our age, in our days of urologists. And I think that the next 20 years, we're going to see even more great stuff.
Well, certainly some great points there. One of the meeting sessions included an interesting debate, which you were involved with as one of the presenters, Battle of the Big Prostates, including looking at various clinical scenarios on how robotic simple prostatectomy, HOLEP, and aquablation compared, and maybe which one had the edge for each situation in these larger prostates. And what were some of the takeaways that you saw from this debate?
So yeah, that was a good half an hour discussion. There was Bradley Gill, myself, and I think Dr. Alex Glazer from UChicago. And each one of us were sort of assigned the different techniques. And I do all three. I also do robotic prostatectomy and I do HOLEP, and just pick your energy. The end point is complete removal of the transition zone, which is what is highly suggested for prostates large, and Canadian standards over 80 grams, that matches of European. The US is just considered large prostates, doesn't really have a number. But number one, most patients don't know their prostate size. If I ask you your weight and height, you can check that. Outside of having an ultrasound, transabdominal, transrectal, or an MRI of your prostate, not everyone knows that. So that's probably the biggest link, and it's really easy. And hopefully we'll devise go to the pharmacy, I sit down to do my blood pressure, a little ultrasound can quickly check and pump out a prostate volume. It's really not hard. X times Y times Z times pi over 6. It's simple as that. It may take 15 seconds. That would be great. So coming into the large prostates now, the battle was 3 different scenarios. You have someone who's on blood thinners. Well, lasers have the advantage. You're not going to cut the abdomen open to excise out using your finger, a very traditional technique. I think that has an advantage. In one of the other scenarios where you have a big bladder diverticulum or a 5 centimeter bladder stone, you need that access point to get that out. And especially in Canadian centers, we have 8 to 4. You have to finish your surgeries by a certain amount of time. It's time efficient versus sitting with the laser and painting the prostate for 3 hours. I mean, I can do it. Can I find other efficient ways? And was the patient fit to undergo that long of a surgery? So I think each one had their selected benefits. And I don't think there's a winner. You have to look at case to case and understand, and good discussion was had between them all. And the one that aquablation won was the gentleman who has a younger partner and looking to have more children, and ejaculation was very important. So certainly that's the winner in aquablation. It's fast. All these cases we can do relatively within an hour or so. And fortunately in our environment too, we're doing same day discharge as well. Those are the technologies. The question is, out there in the community, how many of urologists, if we ask the question of all the, 5,000 urologists out there in practice, maybe more, I don't know the exact number, what percent of them do all three of those techniques? And I think that's the question. We say HoLEP's a great surgery, but only 5% of urologists after 30 years are doing this technique. Why is that? That's the question we should be asking. It's a great surgery, but comes with a strong learning curve. So it's nice to have the battle, but it's like, what can win, a Ferrari or a Formula One car? Well, I don't have those in my driveway, so I can't necessarily go ahead and say which one's the winner. I got my Honda. There's wishful thinking and there's practicality. And we live in a bubble in North America. Think about the rest of the world. And how do you call that a global standard if not everyone has access to that?
And that was one thing too, in terms of, we talked about and I offer 2 of those treatments, aquablation and robotic simple prostatectomy. I've not had the training for the HoLEP, but I know surgeons that I can get patients to that need that technology. And I think that's important too, is just as a urologist, really trying to look at the patient preferences, patient anatomy, the size, and try to, if you don't offer that technology, but you feel that there's a technology that would be better suited for that patient, to get that patient to one of your colleagues that does perform that procedure and to kind of get them, the right treatment.
Absolutely. I think that's my message, and especially with technology and the podcasts like this, patients want to become more informed. We're dealing with patients who have access to the internet, and a lot of data is out there. And I think always make sure you check PubMed. It's not on the local podcast, or you got to look at where the source is. But the biggest one is the guidelines, the AUA. So if you're interested, type up AUA BPH guidelines. That's our Bible, our Quran, or Torah, whatever denomination you are. That's our listing of up-to-date stuff, and it's great stuff there. Learn about it and ask questions. And I think that's like anything else, the 5 Ps, the planning and preparation, prevent poor performance. So same thing for the patient. Before you go for your interview with your physician, get your information. Don't just go there with, hey doc, I'm sick, take care of me. Try to get involved, understand, ask the right questions, and understand what maybe technology. Just know right now that there's a lot of different options, and there's different ones that are unique for different patient needs.
So lastly, urologists have all seen the patient who comes to us being managed with BPH medication for many, many years. We look in their bladder and they already have visible signs of bladder health compromise, significant bladder trabeculation, diverticulum, and compromised bladder function. The paradigm with how we manage men is certainly trending toward earlier intervention to avoid this irreversible damage to the bladder. We certainly have a long way to go and would love to get your opinion on how we as a specialty can improve on what is needed to help these men sooner.
Now that's the $1 million question. That's the question that I think we started off the whole session and also ended the SOPD with. The first was, is there genetic markers? If you think about cancer, we can check in the blood and do these biomarkers that detect, hey, you're at high risk. You shouldn't do active surveillance, or you should get treatment. Or in other cancers, hey, we're going to give you this treatment because you're going to do better. We don't really have that in BPH. We have X times Y times Z times pi over 6, your prostate volume, how old are you, and your medical status. It would be great if we could detect some other marker that's someone urinates and we'll check in their urine. They have a stress marker, like a troponin, like their bladder is stressed. Could we determine that? That would be, or you pee in the toilet and it turns pink, time to do something. The Eurocuff gives us a glimpse of that. For us in practical day-to-day, we look at the Euroflow and we say, oh, your flow is getting slower, and your PVR, the bladder scan, a little ultrasound we put on the abdomen to see what's left behind after urinating, may go up. So we're not emptying as well. That's when the flag comes up. We discuss that. And unfortunately, not everyone has access to it, or we don't go through the granularity of differences. Enter AI. I think that's going to be our next move. Certainly here, our kids are seeing it. And like we saw with ChatGPT, 10 million or 100 million users within a month and a half after its release, the first ever of its kind of that degree of uptake. So the technology is there. And the idea would be, is there a way that we have this empowering machinery, generative AI, so it's going to be able to question the patient before they come to see us? do this sort of background check to see what was the last couple of visits like? What were those numbers? And could we look into other tests as they become available, like biomarkers, helping us predict and say, look, we should get in earlier. And at the same time, too, help us generate better notes. As you know, too, as a specialty, it's the highest depression rate, burnout rate in some of the news reports the last 2 years. We spend over 70% of our encounters with a computer rather than the patient. So if we can turn some of that more to the patient, ask better questions or gather more information, and at the same time be able to do what we love and what we train, like these diplomas on my wall behind me, do the physician work versus the typing and the scavenging, the gathering of the information. That's where AI, I think, is going to help us turn the tide and be able to be more proficient. At the same time, to bring in those other technologies that are being studied right now that are going to help predict who's to get in earlier and offer better treatment.
Well, Dr. Zorn, any final thoughts today for our listeners?
Well, I guess number one, be aware for all men, there's a secondary puberty. It's for your prostate. You'll tend to lose your hair, get some gray hair. Your prostate's going to grow. You don't see it. Your bladder compensates initially. And by the time you get into trouble, usually you're more advanced than you think. So number one, ask questions, speak to your primary care or your other providers to say, hey, look, talk about prostate health, to check my PSA. What are the form of quick imaging I can get to see my prostate size? Because we know it's going to grow 2, 3, 4% a year. And to take charge, to ask questions, to get involved. And if you are suffering and you're thinking, hey, I've got some urinary symptoms, go online, check up your IPSS score, International Prostate Symptom Score. And based on that number, you seek out attention to a urologist in your community and have that discussion of what's there to be offered. And just like anything else, know your numbers, ask the questions, make an informed decision.
Well, it was awesome having you as a guest today on the Prostate Health Podcast. You certainly delivered solid gold wrap up of the recent SOPPD conference in Dallas. We really appreciate you taking time out of your busy schedule to join us today on the show. Thanks again.
Well, thank you very much for having me on the show. It's been a pleasure. And for all the urologists that are listening out there, feel free to sign up for this upcoming year's AUA SOPPD meeting, which will be taking place on May the 6th in San Antonio. So please visit SOPPD, Society of Benign Prostatic Disease, become a member, join up, and join us at the AUA for further discussion, further developments in the field of BPH.
Thank you again for listening to the Prostate Health Podcast. For those of you wanting to dive in even deeper, make sure to check out the Prostate Health Academy, which offers comprehensive and easy to navigate lessons that I have prepared for you. There's also an active private community forum, and I am there every day providing support, insight, and answering questions. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. Well, that's it for today. We will see you at the next episode.